Hello, anesthesiologists, and welcome. Today we're diving deep into the essentials of pediatric anesthesia. We're going to unpack the unique physiological landscape of our youngest patients and really see how it dictates every single decision we make from the moment we meet them to the time they're safely in recovery.
All right, let's just get this on the table right away, because it's the single most important rule in this entire field. If you take away only one thing, let it be this. Children are not just scaled-down adults. I mean, it seems obvious, right? But their physiology is fundamentally completely different. And this isn't some academic talking point. It's the reality that shapes every single thing we do. Forgetting this, even for a second, can lead to some really serious trouble. But when you truly get it, when you internalize it, that's the key to providing safe, elegant, and effective care.
So, let's start by looking at the physiological blueprint of a neonate and an infant. You can think of this as the owner's manual we have to master before we can even think about building a safe anesthetic plan. This first section is all about that critical and often pretty fragile transition from life inside the womb to life out here in the world.
Okay, check this out. It's called transitional circulation, and it's absolutely fascinating. At birth, the whole cardiovascular system does this incredible magic trick, switching from getting oxygen from the placenta to getting it from the lungs. But here's the catch. That new setup is incredibly fragile. For the first few weeks, any kind of stressor, we're talking hypoxia, hypercarbia, acidosis, can cause the pulmonary artery pressure to just spike. And when that happens, the system can actually flip-flop right back to the old fetal circulation. You get a massive right-to-left shunt, deoxygenated blood bypassing the lungs entirely. And the result? It's a catastrophic downward spiral into severe hypoxemia. And here's the really scary part. It might not respond to just giving 100% oxygen. This is a true pediatric emergency.
And believe me, that fragile circulatory system is just the tip of the iceberg. So now, let's really drill down into the most important physiological differences across the board. Cardiovascular, respiratory, and renal systems. These are the distinctions that have the most direct, in-your-face consequences for how we manage an anesthetic.
This table, right here, nails 3 absolute truths about the neonatal heart that you have to know. First, and this is a big one, cardiac output is almost entirely dependent on heart rate. Their little hearts are stiff and just can't increase stroke volume to compensate. So what does that mean for us? It means bradycardia in an infant is a full-blown hemodynamic crisis. It's hypoxia until proven otherwise, and you have to treat it aggressively. Second, that same stiff ventricle makes them incredibly sensitive to both volume overload and increased afterload. You can push them into heart failure really quickly. And third, their calcium stores are immature. The heart is way more dependent on the calcium that's just floating around in the blood, which also makes it far more susceptible to the depressant effects of our volatile anesthetics.
Okay, let's talk about the airway, because the differences here are just as dramatic. You can't just think of the infant airway as a tiny version of an adult's. The whole geometry is different. You can see the larynx sits much higher, up at C3, C4, which is why a straight blade is often your best friend. The epiglottis is floppy and kind of omega-shaped, making it a real pain to control sometimes. But here it is, the most critical difference of all, the shape. The infant larynx is a funnel, and its narrowest point is below the cords, at the cricoid cartilage. This one single fact explains why a tube that slips right through the cords can suddenly get tight. It's why just a millimeter of swelling in that spot can cause major airway obstruction after you extubate.
In many ways, the pediatric respiratory system is almost designed for failure when it's under stress. First off, their oxygen consumption is just massive. We're talking 2 to 3 times that of an adult per kilogram. But the tools they have to meet that crazy demand are pretty inefficient. Their chest wall is super compliant, almost like cartilage, so it provides poor support. And their muscles, they get tired really easily. So you combine this huge demand with an inefficient system and a tiny little oxygen reserve, their functional residual capacity. And what do you get? You get the perfect storm for rapid, profound, and terrifying desaturation the second they become apneic.
And that brings us to the kidneys. Just take a look at these numbers for the glomerular filtration rate. A GFR of 24 on day 1 of life. A week later, it's only up to 38. It doesn't even get close to adult levels until they're 1 or 2 years old. The implications of this are huge. It means newborns are terrible at excreting both water and solutes, which makes them vulnerable to both dehydration and fluid overload. And, critically for us, it means the half-life of any drug that's cleared by the kidneys, think about many antibiotics, some muscle relaxants, is going to be significantly longer. We absolutely have to extend our dosing intervals to avoid accumulation and toxicity.
All right, so we've established that physiological blueprint. Now let's start applying it to a real-world scenario that, let's be honest, we all face constantly.
The child who shows up for their tonsillectomy with a runny nose. The upper respiratory infection, or URI.
Taking a child with a URI to the operating room significantly cranks up the risk of what we call perioperative respiratory adverse events, or PREAs. You know the list: laryngospasm, bronchospasm, the whole shebang. The risk is definitely highest in infants under 1, kids who are around cigarette smoke, and for any kind of airway surgery. But here's the clinical pearl that can really catch you off guard. Even after the sniffles and the cough are long gone, that underlying bronchial hyperreactivity can stick around for up to 6 weeks. That means the risk is still elevated long after the child looks and sounds perfectly healthy.
So what do we do? Well, this algorithm gives us a fantastic framework for that tough decision. Let's walk through it. On one end, you have a mild cold, clear, runny nose, maybe a dry cough. We can usually proceed, but it's a good idea to consider pre-treating with some salbutamol. On the other extreme, a severe cold, wheezing, fever, the child just feels awful. The risk is just too high. We postpone, period. Reschedule in at least 2 weeks. The real art of anesthesia comes in that moderate gray area, the kid with the moist, junky cough or some purulent congestion. This is where we have to stop and really weigh the risks versus the benefits of the surgery. And if we do proceed, we change our plan. Maybe we use an LMA instead of an ETT, or we opt for an IV induction with propofol, which seems to be a bit protective.
Awesome. Let's move on to 3 other absolute cornerstones of modern pediatric practice: fluids, fasting, and our ventilation strategies. Our thinking in all 3 of these areas has changed dramatically as we've gotten a better handle on pediatric physiology.
This slide right here highlights one of the single biggest safety improvements in our field. For decades, the standard was to give hypotonic fluids like D5 normal saline. The thinking was we needed to provide free water. We now know without a doubt that this was a dangerous practice. It led to cases of severe, sometimes fatal, iatrogenic hyponatremia and cerebral edema. The modern standard of care, as you see on the right, is absolutely clear. We use isotonic solutions like lactated ringers or plasmolite. The goal is to maintain intravascular volume. This isn't just a slight change in preference. This is a fundamental practice change that has literally saved lives.
Our whole approach to fasting has also gotten a lot smarter and, frankly, a lot more humane. First, we have to recognize the data. The risk of aspiration in a healthy kid is incredibly low, maybe 1 or 2 in 10,000. Then you have to weigh that tiny risk against the very real risks of prolonged fasting. Dehydration, hypoglycemia, not to mention a miserable, irritable kid and stressed-out parents. The classic 6-4-2 rule is still a great guideline: 6 hours for solids, 4 for breast milk, 2 for clear fluids. But what's really exciting is the new evidence, especially out of Europe, suggesting that even a 1-hour fast for clear fluids is safe. This is a huge paradigm shift away from making kids needlessly and miserably thirsty.
All right, here's a simple number that makes a huge difference in the OR: 5 centimeters of water. Routinely applying a PEEP of 5 is absolutely crucial. Think of it like a pneumatic splint for their floppy, compliant airways. It helps prevent atelectasis and keeps their oxygenation solid throughout the case.
And here's another critical number for lung protection. We're all about lower tidal volumes now, right? We want to target a range of 6 to 10 mLs per kilogram. This gives us perfectly good ventilation while minimizing the risk of barotrauma to their delicate lungs. Trying to push volumes above 10 should really be avoided.
Okay, for our last section, let's bring all these concepts together and really focus on the big picture: safety in modern pediatric anesthesia. We'll touch on the psychological side of care and then hit the key factors that really contribute to great outcomes.
You know, safe anesthesia isn't just about physiology and pharmacology. It's also about psychology. A terrified child is at a higher risk for adverse events. And as this slide shows so well, what they're afraid of changes as they grow up. So our approach has to change too. Toddlers are terrified of being separated from their parents, so we use distraction: iPads, toys, stories. Preschoolers have this fear of bodily harm, so reassurance and therapeutic play are key. And then you get to adolescents. Their biggest fear? Loss of control. They need us to respect their autonomy, acknowledge their fears, and give them clear explanations. Tailoring our approach like this is an incredibly powerful, non-pharmacological tool.
So, what are the absolute key safety factors that define modern practice? First, you got to know your enemy. The data is clear. The majority of pediatric cardiac arrests are caused by respiratory events or hypovolemia, not an anesthetic overdose. Second, we have to know who is most at risk: the very young, especially infants, the very sick, and anyone having emergency surgery. And this last part is so important. Multiple studies have shown a direct link between the anesthesiologist's experience with kids and lower complication rates. That experience, of course, has to be backed up by the right resources, like a well-stocked difficult airway cart and lipid emulsion for local anesthetic toxicity. You know, we've talked about all the incredible progress we've made in making pediatric anesthesia safer right here, right now. We are better than we have ever been at getting our patients safely through surgery. But this quote is a really important reminder that our responsibility doesn't just end when the patient goes to the PACU. Anesthesia is a profound physiological event, especially for developing brain and body.
And that really leads us to the final, and maybe the most important question that our specialty is grappling with today. Well, we have more and more evidence that a single short anesthetic probably doesn't have a lasting negative impact. The science is far from settled. So the crucial question for all of us to think about is this: how do we continue to perfect the science of immediate perioperative safety while at the same time staying vigilant and helping with the research that will protect the long-term neurodevelopmental future of the children we take care of? That right there is the challenge that's going to define the next generation of pediatric anesthesia.